to the cloud. Sweet. All right, Sam, I think everyone here knows you, but do you want to give a little brief intro of where you currently are, and then we can kind of dive into the structure for today?
Sure, absolutely. So yeah, I'm Sam. Nice to meet you guys. You can some of you may have seen me before online. I've also been a clinical athlete member slash presenter slash on the podcast. I was actually one of the original student members and also one of the student ambassadors. So big fan of clinical athlete. Been involved with it for a long time. I think it does amazing service for people, and it's awesome to see more people involved in it now. When we used to do this, we'd have like 5 people show up to something like this. So it's great to see
This is
more.
not clinical athlete related, by the way. This is just my
What's
own
that?
private journal club. But we got some clinical. We got Nick, Logan, Derek. We got a good amount of people that are on clinical athlete, but for sure this is just my own separate thing. But I love
That's
that.
like a free plug for it. So there you go.
Yeah, I love that. Thank you for that.
Sam just logs off. What does that mean?
Oh, I was just saying, like, you thought it was part of clinical athlete, and then you're like, okay,
yeah.
bye.
Peace out. Yeah. And so now I'm up in BC, British Columbia, Canada. I practice here. I have a small little practice inside of a weightlifting gym, and then I also go to 2 other gyms here in town upon request. So there's a performance gym, and then there's also a CrossFit gym. They each have a little space where I can go in, set up my table, see athletes on as necessary, and then online businesses. I have a company called Citizen Athletics, and then a company called E3 Rehab. So then I create fitness programming with Citizen, and E3 Rehab has lots of online educational stuff for rehab professionals. Yeah.
Hell yeah. Perfect. So you wanted to kind of go down the shoulder impingement rabbit hole, and you chose these 3 papers. Do you want to talk about like why you chose these 3 specifically?
Yeah, absolutely. So basically, like, the general topic was along the lines of shoulder impingement. So I think that these papers provide a nice little interesting contrast between each other. So we've got the Tucker paper, which looked at the Hawkins-Kennedy test. So that's where we'll start. And we can look at the Michener paper, which was a look at subacromial space and some possible implications with that. And then we can also look at the classification system that Michener was involved with for the STAR system. So it gives it a nice little contrasting breakdown, especially because you guys have previously looked at the frozen shoulder. So that's actually involved in the STAR one. So you'll see where they put that versus in other places and why. And then I know that Chris mentioned that you guys are going to have special tests next week. So then this will give a nice little lead into it as well. So I assume everybody's read all of these. So the first thing that we'll just do is, like, we're going to start off with the Tucker paper and just kind of go through and look at sort of the information on what they did, what they found, and possibly some implications for that. So who would like to start? I'll let you guys take lead. I think Kevin or Logan want to go because they also messaged. So.
All right. I don't think I probably have anything too crazy to share, but I just thought it was interesting that, and not surprising at all, that Hawkins-Kennedy test compressed more than just one region. And it did mention that that might be why a lot of our tests are so non-specific, is because they're not just compressing one area, they're compressing multiple areas around the shoulder.
Absolutely. So what did they do in the test? Like, how were they able to decide what was even having pressure?
They used these force sensitive resistors, the transducers, and they put, was it 4 or 5 of them? One in, let's see, there was one in the anterior acromion, posterior acromion, midpoint of the coracoacromial ligament, and then the posterior coracoid process. And then they did the test and measured the pressure along each transducer.
Did anybody have trouble with the fact that it was one 80-some-odd-year-old person? They fixed the scapula and were missing damn near all of the shoulder around this pro section? I mean, the reality is we're compressing a whole lot of shit. So it doesn't matter one way or the other, but I'm not sure that we can gain a whole lot from one singular individual with things that aren't anything close to what we're doing actually in clinic. But I don't think it actually will change the results if they did it the other way. So.
Yeah, that tripped me out that it was one cadaver, that there was already things like they took out the bursa. They were 87. They weren't alive. So it's kind of tough.
And they did mention that towards the end, that was like one of their big limitations, right? Like they even said at the end, like, yeah, this is kind of limited because of all that.
Well, I mean, they even go so far as to say, okay, we only went to 60 degrees, right? Because we're fixing the scapula and we're assuming this humeral rhythm, but okay, we can all argue whether or not that there's a dysfunction in the scapular humeral rhythm with or without impingement, et cetera, et cetera. I mean, we can go down that rabbit hole as well, but we've got a fixed scapula and we're only taking 60 degrees and we're just internally rotating to like 50 degrees. I mean, that's not the described test. That you're kind of making a justification for their limits based on the fixed scapula, but you know, is that clinically relevant? I don't think it actually, again, changes the final findings, but it does just make you kind of question what's the relevance.
Yeah, I mean, just globally from this paper, they have the force sensors in place and compression happens everywhere. Like it would be nice if there were more than one cadaver. But that was just my big takeaway from it is like, all right, we're moving stuff and everything is affected through the shoulder. So it's like, I don't know.
Well, again, the overall idea of impingement is it's subacromial. So in that regard, right, we're on spot because this is any of that shit subacromial, we're impinging, right? It's not what they originally said as far as the supraspinatus, and we're going to be able to identify an individual tendon, but we're compressing shit under the subacromial arch. Okay, so we know we have some sensitized shit under there, but now how does that drive any decision from there is what we've got to get to.
I also, and I don't know if it's just me, but like my interpretation of impingement, like prior to PT school, was just like two bones or structures like approximating each other. And now in like PT school, it's very much like if something's impinging, you're going to explode. So Sam, do you have like a good working definition of like impingement? Because I'm assuming everyone impinges when they go overhead, but are they symptomatic or not? But then like, if they are, can you confidently say that it's the structures getting closer that's causing the pain?
Yeah, so I do use, as far as impingement goes, I stick with more of the operational definition that it is just two structures approximating. Then from a standpoint of the actual quote unquote condition, I don't utilize the term impingement because I don't think that it's necessarily as relevant. So I think, you know, you gave me the lovely task of only picking 2 papers. I sent you 3. If we were like legitimately breaking down impingement, I would have sent you way more. So the simplest thing is like, you know, I picked this paper specifically because I think it does give us an interesting contrast to number one, the whole discussion about the supraspinatus being the primary culprit in the classical definition that you hear about with impingement. It also starts to like highlight, as Paul had said, there's so many things being compressed. And so realistically, they're all impinging. So how can we utilize that as a terminology, as a description? Because, you know, like everything is impinging. It's like how much is it impinging might be a conversation to have, which we'll discuss in the next one. But it helps to highlight some of the issues that's with the definition from a pathological and diagnostic standpoint. But, you know, like specifically in this paper, I think that we can see, yeah, obviously they have to set it up somehow. Like you have to do some things to create a way to test objectively. And then from here, if they did a follow-up study, now they can start to introduce other variables like, okay, maybe it's more participants, that would be great. Maybe they don't fix the scapula in place. Maybe they're able to connect with a surgeon who lets them sneak in real fast and do this in a live subject. I don't know, that seems like a wild thing to do, but maybe you get someone on board. But at least it's like an initial starting point that starts to poke a significant flaw in the operational thing that you see. You know, like I deal with a lot of individuals online who like freak out anytime I show like an upright row or something. It's like that the supraspinatus is getting destroyed because the argument that they make is it's in reference to Hawkins Kennedy. So like this is like a direct slap in the face to them that this is like clearly not the situation. Now it's not quite the same. There is a key one being the scapula being fixed in place. It doesn't like hold the same argument, but it still highlights that, you know, if we are fixing the scapula and rotating the shit out of the arm, like 50 degrees depends on your definition if that's rotating the shit out of it or not. But, you know, I don't have that much internal, I have probably about 50 degrees. So it's probably my max anyways, with my scapula being fixed. So then, you know, we're relatively pushing it to a really high degree. Now, if you let the scapula move and you maybe try to take it more, you'd still probably end up not having a drastically higher amount because now the scapula is going to start to begin to move. So then the actual motion of the glenohumeral joint is probably going to be relatively similar, but you're going to start to add in another variable that the scapula can rotate, but I don't know if that necessarily is going to drastically change what's going on at the subacromial arch. And if the conversation is primarily about that, if the context is impingement, then this gives us like a pretty good working idea until more information comes out. And there are some follow-up studies that have been done on this. This is just one of the better ones because if you go and look this up on PubMed, you can find additional papers like it. And they're honestly like not necessarily quite as well done when you read the methodology. So this is why I chose this one. But you see pretty consistent information pop out across them all. There's only a few where they didn't find basically the same thing. As you saw, like the only thing relative or related that had a significant like peak pressure in the transducers was the biceps tendon or the rotator interval. And so we don't even see necessarily any of the actual classical rotator cuff muscles involved. They did notice some increase in subscapularis pressure, which is pretty contrasting to, I've never heard anyone report that they thought the subscapularis was involved in shoulder impingement. So it's definitely an interesting shift. But
Do you think the structures would have changed in pressure if it was a live human? Or do you think it'd be the same regardless?
I think that if it was a younger individual, it might be different. And if they didn't also remove like the bursa and whatever else, but I think it'd be extremely similar. You probably just have probably more things that would have impingement because like, I don't know if it would really call like the bursa getting impinged. Like it technically does by the operational definition, but you don't necessarily like think about it that way because it's there to be pushed against. Whereas like the muscle or the tendon, sorry, we don't really think of it as something that should be squeezed on. Like when people think about it, they think that it's supposed to just like slide magically through the joint and not have any pressure on it. But the bursa would technically be undergoing like everything in that space is going to have to get squeezed on. As we talked about with the next paper, the Michener one, like there's probably a good reason for it to happen. Anybody got some additional points on the Tucker paper?
Chris, I was also just gonna go along the lines of like, if it was an actual person, you know, their scapula wouldn't be, you know, bolted in place for it too. So that's like the whole rhythm as well. Like, I don't know. We're told that like 2-to-1 ratio.
Like I said, I think all of those are things that lead to questions, but I'm not sure it changes the eventual component of, right? We're squishing shit together and it's going to basically tell us if shit is sensitized or not. And beyond that, right? Can I say it's the bursa? Can I say it's the tendon? Can I say it's the biceps? Can I say it's this? I can't really say shit, right? I can just say shit sensitized. So what are we going to do about it?
Exactly. Boom. There might be other implications that tell us if something might be more relevant in the conversation if we want to shift over towards the Michener paper. If you guys saw, that's the supraspinatus tendon and subacromial space parameters one. So does anyone want to discuss what they looked at, kind of the general findings?
All right, I'll go. One thing I thought was, I just find it really interesting is like the diagnoses, like categories that they always bucket people in, because we've gotten like 3 different versions of it in class, and I'm like, so it's just like another layer of that. And so just breaking it up into like, and I really like the just subacromial pain syndrome, because we've been taught like all these different like groupings of impingements, or like primary impingement, secondary impingement, but I just really like this broad category that sort of like covers it, because then after that I feel like it's all the groupings that we've learned, I feel like we're almost like splitting hairs sometimes, like when it doesn't necessarily affect how we would, like it doesn't necessarily change our treatment strategy down the road. So I
Kevin,
really,
you are crushing this part, but you're ahead of us.
Oh.
You're on the next paper, so that's okay. Like I agree with your points, but I didn't want to save that, so we're gonna come back to you when we get to that one. Just because,
as you can tell, I was a little stoked about that. Sorry.
yeah, no, that's fantastic. But I think like hopefully this paper that we're going to talk about, the Michener one that's on the imaging, the ultrasonic imaging, that one will hopefully support the statements that you just made. So whoever wants to jump on that one.
I guess I'm gonna give it a shot and we'll kind of see. Looking at this paper, so essentially what they did was they were trying to look at like the thickness of the tendon, like in trying to determine like whether there was any like differences between like a symptomatic versus asymptomatic group. And so I guess what like reading towards the end and seeing like it didn't seem like there was, or it seemed like there was a thicker tendon, right, in some like in the symptomatic group. But what I thought was also interesting though is like like some baseball pitchers who were also asymptomatic, they had a generally thicker tendon as well. So, and I know like baseball gets totally crazy because Chris and I were reading a paper the other day that talked about how some slap tears may actually even be like an adaptation for baseball players, which is wild. So that was my wife. So with that, it's just kind of, I just thought that was very interesting. It's like, just because the tendon is inflamed or thicker than maybe some like control or asymptomatic group doesn't really help us very much with that. Is that kind of on the line of what you were thinking, or?
Yeah, I would say that's half of it. Paul, you want to?
Well, I mean, I have questions about one. Do we have any normative idea, right? Because I'm 6'8", 275 pounds. Somebody who's 5'2", 120 pounds is going to have a different size tendon in general, right? And then we have a relative space of what the subacromial gap is supposed to be, right? So we have this idea of what that percentage is and whether or not that's taking in a certain point of, yeah, Chris,
Jesus Christ, Paul, you never brought this up before? We'll talk about it later.
Yeah, but so do we even have normative values? Do we have an understanding of that these are really larger, or are they just what that norm for that individual is, right? Is that space relevant? We can have an argument or a discussion about that, right? But also, is that a sign of, as they say, intrinsic aspects? Is it hyperemic response on the outside, the peritendon type structure? We don't necessarily know with that diagnostic ultrasound, right? So there's a lot of questions that it brings up to that, and whether or not that's relevant at all in the discussion is something that even they bring up, is maybe the subacromial decompression is maybe important in some of these. But if we look at the other literature on subacromial decompression, is it? Right? So, I mean, where are we on that is one of those things. Again, is this driving? And then they mention in the paper something to reduce the size of the tendon. How the fuck do I do that without reducing the muscle component and everything else? I just don't get it, right? So to me, again, methodology and showing that we've got some space in encroachment, possibly, but all the other things just lead to more questions. So I'm not sure that this will help me make a decision on what I'm supposed to be doing with this individual anyhow.
Yeah,
Paul, first question I think we all need to know: are you really 6'8"? That is Huge.
Yeah,
What?
I'm 6'8" and I'm 275 pounds. I'm just a little bit big.
Savage.
Wow.
Savage. I'm
I
6'4" and like 235, but that's nice job. So first one is you know, Paul, because you brought up this question, it's actually really valuable because they mentioned it briefly in the paper about like the decompression. Have you ever looked at the diagnostic criteria for them to decide if they're going to do a decompression? Because it's actually like they're supposed to look at the humeral distance, but they actually don't necessarily look at the acromion-humeral distance. Like it's not a mandatory thing, and so more often than not, they don't look at that, and then they go in and do the decompression. So it's entirely possible that like just a significant problem within the decompression category, and this is one that's discussed currently with shoulder surgeons, is like, are they inappropriately using that surgical method? Because it could be that they're just the person has like whatever amount of acromial humeral distance, and it's actually a reasonable amount. They don't necessarily need to decompress it, and so they're just like doing the surgery on a shit ton of people that they shouldn't be, and that makes the surgery then look bad because it's inappropriately being used.
Oh yeah, without a doubt, man. Because I worked for a bunch of physicians at one point in time, right? And so if they're going into a shoulder, they're doing a subacromial decompression, right? And 9 times out of 10, they're also doing the distal clavicular excision. And a lot of times, if you talk to the surgeons that I worked with, the biceps tendon is a culprit in most of the pain. So they're doing either a tenotomy or a tenodesis. I mean, they're just, if I'm going in, I'm cleaning every fucking thing out, and then we're going to see what we get at the end. When most of the time it's the forced time off that people need emotionally to be able to give themselves I need to lift a 1 pound weight for a while, right? So the surgery is the excuse to really, really regress. But now I have the excuse of I've had surgery, so I can take the time off. I can lift a 1 pound fucking pink weight for a little while and then build myself back up, where they can't get there without it. I think it's more the latter than it is the cleaning everything out. But my docs cleaned every damn thing out that they could.
Well, I know in your podcast episode with Meekins, where he had that case study with the patient who went in for the scope, and he even knew it was probably going to be more of a placebo effect going into it. So, I mean, even just somebody who already has like the construct of, yeah, it probably won't really do anything other than, give my body a chance to interpret this differently, could also be extremely important. So, I think like you guys were talking about, I mean, having the ramifications or the criteria for the decompression is probably a little faulty. And we probably should look more into other reasons for having that surgical procedure, because like we've all already mentioned, I mean, shit's already getting compressed, every time we lift our arm. So, I mean, is decompressing it even going to be valuable, or is it going to lead to more problems for this person, as we see in some other surgical procedures? So I do think that, it is going to be patient dependent too. Because I mean, if we've been working with somebody, again, in that podcast episode, I mean, it'd been 3 months and this guy was already a beast. He was a triathlon athlete and was doing all kinds of weightlifting, and I guess not all kinds, but he was adding it in, and just no relief whatsoever. And then goes in and gets a minor scope surgery, and the guy's like, I feel fucking great. Like, so, and I know the barbell medicine guys have made that approach as well, with stuff like FAI. And, I know that we see better outcomes with passive approaches with exercise and education, but, sometimes a person just needs to go under the knife, unfortunately.
I do think there's a sociological barrier for many people to regress and to do some of that other kind of stuff, right? I mean, if you look at even the number of spine surgeries in Europe versus what we do here in America and stuff, we have to have that social excuse to take the time to do some of that other kind of stuff, right? We also have the idea of the fix and some of the other kind of shit, but really I think it's more the sociological aspect of we're supposed to be grinding, we're supposed to be pushing, we're supposed to be doing all that shit, and so I need the excuse to get off of that train for a little bit, and the surgery gives me the excuse to get off of that train and then slowly give myself the time to build back up, right? But I needed the excuse, because otherwise I'm looked at a pussy, or I'm not pushing, I'm not this, I'm not strong. This is my excuse, right, socially, to kind of rebuild. And so I do think that there's somewhat of that social context that we miss in research, we miss in some of the other kind of stuff that does play a role in how we're having to deal with things as a human being in our society.
Paul, I was just gonna jump in on, you know, how you mentioned earlier, like how the heck are we going to like reduce the thickness of a tendon? And
Did I say
like,
heck? I don't think I said heck.
oh, right. Sorry. Anyway, so yeah, you were like talking about that, and it just on paper, you're just like, this looks absurd. But then, I mean, and you're even wondering how you're going to do it. But then I kind of was thinking along the lines of like inactivity and just really letting that arm, like, I was kind of thinking along the lines of like post-surgical, or, you know, like, I actually don't know, like, how much does inactivity affect the thickness of a tendon, and like how quickly? Because then I was kind of thinking along that line, because obviously if something's inflamed, it's pissed off, so you're going to stop using it for a while. Like, I didn't know if anyone.
But if we look at
had
the
any.
corollary for what we look at for Achilles tendons, right? We know rest doesn't necessarily lead to anything other than symptom mitigation for a little bit, and then as soon as they go back to loading, the shit comes right back, right? We have to gain more strength, and we talk about building the donut, right? Well, that's just going to thicken a tendon that's got some intrinsic aspect that may be, you know, dying or problematic within. So are we just creating further impingement? Where do we go from there, right? So I'm not sure that this leads me to anywhere that I know that I can have an effective intervention, so to speak, or exercise component to it, because I really don't know how to shrink a tendon while maintaining vitality in some of those tissues.
It's actually very interesting, because I would make a couple of arguments to what you said, Paul. Like, number one, it's super inconsistent, at least across most of the research, if our strength options will actually have a significant impact on the hypertrophy of a tendon.
Right.
We do see it in some, but it's also very inconsistent across tendons and across studies. And that's obviously like methodology, but also the type of tendon might be very, very important. And we see, you know, with like a supraspinatus tendon, it seems to be very different in response to an Achilles tendon. So that might be a factor there where, you know, does loading have a significant impact, at least from a strength and like a resistance training standpoint? Because we do see, like with the baseball players or with individuals that have like chronic shoulder pain, that they are having a thickening. That's obviously not because they're doing resistance training. So like it's thickening in a response for some reason, but maybe not necessarily that. So that's like possibly a factor, but you know, it could be that when the person goes to have the time off, maybe we need to, and they see that benefits because there's that reduction in inflammatory space, or the inflammation that's involving the decrease in space that's available for the tendon. So maybe that person does need rest, because in some cases, like you said earlier, the surgery accommodates them to have rest, and that allows them to calm down, improve. We do see that in some other areas like the low back for occupational workers and some white class individuals, blue collar workers. And so it's entirely possible that, you know, while I love resistance training, it might not be the correct approach. And that's where some study like this that looks at this kind of information, if it were done in a more longitudinal format, to also compare to how symptoms change, and to some, number one, we'd have to have a paper looking at how it compares with symptom change across time, and a follow-up study to actually look at comparing that with interventions to see, like, does this even matter? Can we change any of these factors? And how does that compare to the symptoms across time? Because like you said, like, I don't know how to use this information necessarily for actual care at the moment. It's interesting, and I can definitely ponder about it and use some of the ideas. Like, yeah, I'm probably not going to thin a tendon out, but maybe I can do some different things to reduce the stress on the area, to hopefully decrease some of the space taken up by not this tendon specifically, help things calm down. And that might give a benefit, because I'm also, you know, I'm not a surgeon, so I can't increase the space. So that's kind of basically what I'm going to be left with. But I don't know if that's even going to happen. I don't know if that's even going to be, you know, benefiting the patient, because it's entirely possible that I don't need to even do that. Like you said earlier, when we start to build it up gradually, we see that that generally corresponds with an improvement in symptoms. But you'd think that if I have someone challenge the area, I'm going to possibly thicken the tendon, possibly, or I'm also going to possibly increase the space being taken up by other stuff, such as fluid, from the challenging bout of exercise that we just did. So since we see a decrease in symptoms, maybe the theory behind like what they're looking at is actually wrong.
Right, and without a doubt, I mean, we could just have mechanosensitive stuff, right? And we give it rhythmic stimulation just in general, and now we've decreased the threshold or altered the threshold for where their symptom response is going to be, right? So how long does this effect last? Is it a continuous effect? Because we've all seen in clinic, people go, they leave, they feel really, really good from what we've done, but then 2 days later, they come back in, they're basically almost the same, right? And so did I just have that small mechanoreceptor or neurologic effect that changed things and now they're coming back in? We really don't know anything from this. And is it a hyperemic? All right, so is it just all the tendinous tissues that are swollen, or is it the tendon in itself? And here with the ultrasound, we're ideally seeing that it's the tendon itself, but I'm not sure because I'm not well skilled in ultrasound reading whether or not that's going to show me the peri tissues or just the tendon in and of itself, right? And then again, we go back to, if this stuff is built to be compressed, right? Because, okay, and then how do I rest a rotator cuff when damn near anything I do, push, pull, lift it, it's engaged, right? So I basically have to have almost absolute rest of the shoulder, which may not be a bad thing, right? That's where the sling is and for a short period of time, but then what are we doing for capacity at a certain point in time, and how do we regain that? And so the rest and then the slow progression may be necessary. And that's where I argue, again, the surgery gives the excuse for people to have that, where otherwise they may not be willing to do that, right? You know, unless it's a traumatic injury or something else. A lot of times it's just, I got to push through shit. I got to not be a pussy. I got to not do whatever it is. But that's just not really the realities, right? Sometimes. And so the surgery gives them the excuse. And so we need to have some of these discussions and figure out, where is this leading us, or what are we going to do? And, you know, in my practice, I've been where I thought we were going to be very specific. We've done all this kind of shit, right? But it didn't ever change what I was doing from my initial eval. So I stopped doing all that shit just simply without any research, just going, none of this shit is telling me what I'm supposed to be doing with the human being afterwards, right? So I'm going to just go based off of treat what I see, what hurts, don't do, and then build that up slowly as capacity and work around it. I didn't need all that other kind of stuff, right? And so it's that same kind of a process. We're just now getting to it quicker, right? I mean, students are now coming out understanding, I don't need to do some of this kind of shit because it may not guide me. That's perfectly good, but they're being instructed that they need this. Well, you got to fine tune this so you know what exact tendon. Show me where I can work just the supraspinatus. Anybody? Right? I just don't think that we have those capacities. So I'm not sure why we go down that road of the rabbit hole of it's this individual tendon, because I'm not sure that we can work that specific tendon. Right? And so for that, what are we going to do about it? And is all of this going to lead to things? And I think that leads down to next week's stuff with Chris and stuff. But really, for impingement, all this shit is being compressed, and I just need to learn, what am I supposed to do with that? And I'm not sure whether or not I can alter that tendon. And I'll agree with you, the Achilles is going to be a very different tendon than probably the upper extremities tendons, both in its construct and, you know, it's got some torsional components, it's got some other things built into it. But, all right, but most of our research is there. I don't have a whole lot on what I'm going to do tendon-wise here, so I'm using that as the extrapolation, and I'm not sure that it works well.
So actually, just kind of, Paul, since you brought it up, and I've as we've gone through like the shoulder in lab, like there's the manual assessment of like the laxity of the joint capsule. Anyway, but then what really gets me is like, then we also have different tests for like instability of the shoulder. And in my mind, like instability makes more sense because like Paul, you said, it's how the patient presents to you. Like because you might have a really lax capsule, but like the person might feel totally fine. So like, and I'm not exactly sure how our treatment would change if they had no instability, but if the capsule felt lax or if it felt shortened or tight. And so then for me, I'm like, why are we, it almost falls into like unnecessary like medical testing because it's not really changing how we'd approach the rehab after the assessment.
I do think we get caught up at times, like trying to find what stiff or lax is, because I think in some people it is like a normal adaptation for them. I know in my athletic training time, like I got to work with some baseball players, and based off of like what we were taught in school and looking at, quote unquote laxity and hypermobility, I mean, a lot of those pitchers had crazy amount of movement and external and internal rotation, hyperextension at the elbow. I mean, you're looking at these guys going, I mean, if I breathe on you, your shoulder is just going to shoot out. But again, like that player has adapted over time to his specific sport and what is required of him to, continue to do that. Now, is that every pitcher? No, we had other pitchers who hardly had any movement in their arm. So again, I think, it gets tough when you try and like pinpoint what specifically is tight or lax. And is it even necessary to improve? I mean, we have these broad ranges of motion that we're supposed to quote unquote hit with people. But I mean, if they're even on both sides and they don't have any pain or discomfort and they're functioning normally, I mean, is it even necessary to address those things? Like, is that really important? Or am I just adding to the fire that is, the issue that they're there for? So, I mean, I think sometimes we can get caught up in that. Now, if there's a gross difference between sides, I think you could possibly make that argument that, okay, this is something that I definitely, need to look at. But again, I think it's hard because in school they make it absolutes where it's, if this isn't, where it's supposed to be, then you have to address it. But again, I think we put people into boxes that don't necessarily need to be in that box. Like, again, I think it is very patient dependent, even though that's, an easy cop out.
Derek, how would you differentiate between like a gross difference and a not gross difference?
Well, I think the biggest thing for me would be if there's a large difference in range of motion, because I know one of the things they look at in baseball, and again, I'm not huge in baseball, like I don't know a ton about it, but like between internal and external rotation between arms was something that they always brought up as being important, that it needed to be relatively close between sides, and that there was a likelihood that it could increase injury. Now, again, I know that we're not great at predicting injury. But again, I mean, if I saw a pitcher that between internal and external rotation between one arm and the other had like 40 or 50 degrees difference, it may be something that I'm looking at to see, okay, well, what is causing that? Especially if they present with some pain and discomfort and things like that. Again, I think it's hard because I haven't had a ton of time in clinic to really describe what like a gross difference would be. Yeah, and that's a good point, because if one's a throwing arm and the other one's not, I mean, doesn't really matter. So,
Well, so that's actually like, so I'm by no means a baseball expert, but I've done a fair bit of research on baseball and then also on handball recently. So I can speak to some of the overhead stuff as a general. And I also work with a ton of swimmers, and a lot of this stuff to some degree. And we do see for sure, number one, with a throwing athlete, a distinct difference side to side in external versus internal rotation. But what it seems to be, as a general, from a lot of the research on it, it seems to be more important, not that they necessarily have the same external on each side, the same internal on each side, more the total arcing motion. Generally, you'll see like the number thrown out that it's like 170 to 180 degrees total motion as like a general identifier, that if they have less than that, they might be at an increased risk. So, like if you have 120 degrees of external and then 30 degrees of internal, well, that might be a risk, and that might be where you want to look to change something. But we don't necessarily have like super consistent information on that. So for instance, because like there's a lot on handball, just because it's like a huge sport in Europe and they do a lot of relatively good research. And you're mentioning like, okay, well, maybe it's not necessarily a big deal if they have like ton of motion one way, ton of motion the other way, as long as it's similar side to side. But like in handball, they have identified that if a throwing athlete has a significant increase in external rotation, that actually is an increased risk factor, particularly if that individual doesn't have an increase in decelerating external rotation, so like eccentric external rotation strength. And so it's probably because as you get further and further back, you're able to generate more general torque going forward. And so then if you can't slow that down, then you're more likely to have an issue in tearing something. What that is, I don't know. That's one of the reasons why you see a lot of eccentric external rotation strength being focused on in different throwing populations. Like I mentioned, I work with a ton of swimmers, so they inconsistently have a lot of external rotation, but they usually have a shit ton of internal rotation. Like I just saw a girl yesterday and she had like 110 degrees of external rotation, and then she had about 110 degrees of internal rotation. So she had like I could almost flip her arm around. It freaked me out. But she had that on both sides. And but if you looked at her her eccentric strength going in both directions, it was very, very poor. But she's an Olympic time trial swimmer here in like tentatively on Team Canada. So like she's able to perform at a super high level, but she's also relatively young. So will her low strength maybe be at a point where she might put herself at an injury risk with a high amount of volume that she does? So it's a consideration for me that's one of the things I'm going to focus on. So I'm not going to look to change her range of motion or anything like that. It's just like purely, I'm going to try to develop more strength, particularly in an eccentric fashion. So
How are
Sam,
you?
oh, go ahead, Nick. Go ahead.
How are you measuring the eccentric strength for that? Like with that patient you did yesterday.
Yeah, so I have like a inline pole that I set up, and then what my job is, like I try to see if I can progressively start to pull on it. So I set her up in an extra rotated supported position, and then I actually start to pull on it and see what the number is. So it's not a super precise system, but it gives me a number to work with. And then I also do a secondary test for like a endurance strength thing, and I have her set up in the same position. And then I have her hold she's pretty small, so she only uses a 5-pound dumbbell. Then I have her pump out max reps with it, and then I compare side to side, and we're going to use it as a test across time. So I don't have an isokinetic dynamometer, so I just like work with what I got. And it absolutely has a fair amount of error in it, but it gives me data to work with and try to compare with across time. So I'm going to do it roughly every 8 weeks to see, like, especially as her, right now they just got back in the pool 3 weeks ago. And so then I did the test with her right before she got in the pool. I'll do it again after 8 weeks to see like how her volume has changed and seeing if there's a big decrease in any of those markers. And then we'll just keep monitoring after time.
Sam, I was going to ask, in those handball studies that you were referring to, because this is the first I've heard that the increase in external rotation isn't necessarily resultant from humeral torsion, right? Because there's an adaptation that occurs. The old idea of GERD was ruled out and kind of looked at as far as there's actually some humeral torsion that occurs. Did they actually look at the relevance of the epicondyles to the tuberosity type stuff up at the shoulder to see what external rotation bony changes had occurred to allow for some of that external rotation, so that we can see that it's actually soft tissues that are being stretched out a little bit more relative to the bone? Because I've always heard that a lot of that adaptation is secondary to not just soft tissue, but actually bony changes, because we've been throwing for our whole life and the bone starts to build trabeculi that allow us to do that.
So I know that that's been seen in baseball. I can't speak specifically on handball, especially because like I've mostly just like looked at the stuff around injury prevention, and then that it just discusses the various risk factors that have been identified. So, but I don't think whether it's been soft tissue or bony, like, because we just see that as a general risk factor, particularly when compared to eccentric strength. Like that's one of the, there's been a few studies that have identified it as general increases in extra rotation being an identifier, but then they've also done the follow-up studies to then compare within those people, if they compare it to a change in eccentric strength or eccentric to internal rotation strength. That's the other one that they use. If the improvement in whoever has the higher levels of external rotation strength seems to be more preventative from a future shoulder injury. So definitely look at that. It is interesting that you mentioned that, Paul, because they've also seen like a similar thing with the hip for FAI and like torsional sports, but they look at some of the ones that are on that, and if they present with it, and they look at like this thing around like puberty time participation is what they call it, and if individuals get into a sport after puberty time, they might not have the same bony changes, and so yeah, so it's an random information for you guys.
Yeah.
Another piece of random information from this study before we move on, just before I forget. Did anyone notice like the degrees of range of motion that they mentioned that the impingement starts to happen at in this? Just because like most of the time we hear about like the painful arc, or that like 90 degrees is like the peak time of like impingement. There's like 2 points that they mention it in here. And it's because for anyone that doesn't know, Lori Michener is this researcher, and then she also has a husband who's like a radiology arthroscopic specialist as a husband. So then they do like lots of studies together. Also personally, she mentions this in the podcast study you did with her. But they've identified that around like peak impingement is actually around like 60 degrees of arm elevation. So it's actually interesting because once you get past that point, it actually decreases in total amount of impingement. Yeah.
Sam, does that change anything, like depending on where someone has a painful, like where in the range, or is it just kind of like does that provide any value to you?
It tells me that the whole impingement thing from a standpoint of like structural tissue is probably less relevant in the people that have pain at higher degrees of range of motion. Like someone came to me and said, as they lift up their arm, they have peak pain at 60 degrees. I'd be like more inclined to think at least that there's possibly more relevance to this part of the aspect. Whereas like if I'm working with someone that has like peak pain 90, 120 degrees, where we're actually seeing a decrease in possibly subacromial space impingement, then I'm not that I really focus on it anyways, but I would at least less in my mind think about it. So yeah. So
Did she mention whether what was that secondary to we've got more deltoid driving up at that point in time, and we haven't really kicked in the rotator cuff to really start to slide down, so we have more glide than slide, so to speak, within the arthrokinematics there?
I don't think she mentioned.
Okay, because we see that some in like, at least in my group that I worked with previously, if they didn't have on a total shoulder, right? So if they didn't have the glenoid quite right isometrically, right? If it was a little too shallow or something, they'd have this huge drive up, right? Where the deltoids are way overpowering everything and just driving everything up. And so and you couldn't get enough cuff to do that, because we've changed the length tension relationship of the cuff, and it would just drive up, and then they'd end up having to shave a whole lot of their chromium off and do all these secondary kind of components to it because of that. And so I was just wondering if she had mentioned any of that.
No, but I'm somewhat friends with her, so maybe I'll ask her. So, all right, now, Kevin, you ready? We're jumping to you. Tell us about the STAR classification and how jazzed you are for it.
No, his screen is black. This could be bad.
He's sprinting through his apartment.
There
he is.
Sorry, I have two batshit cats who just are always trying to kill each other. So they're not dead now. Are we going into the STAR one, which I figured? Okay, so I'll just open it up. Does anyone want to talk about anything before I go into like the bucketing system of like the diagnoses? Cool. All right, let me get back up on my soapbox. Where was I? So there's so many freaking different ways to like bucket and categorize like these different deficits, I guess, based on like their symptoms and what they're having. And so I really like just how broad the subacromial like pain syndrome was, because like I was talking about with like primary impingement, secondary impingement, and then like all the different like groupings of impingements as well. I'm like, sometimes I feel like it's splitting hairs, and I'm not quite sure how that's going to change my treatment down the road. But obviously, if it's something like, okay, someone's super hypermobile, I guess like until I came to this, I felt like when we were talking about impingement, the best thing I liked was just primary or secondary, where primary is the hypomobile, and then secondary is like impingement due to hypermobility, because then that seems like practical to me in how I'm going to like guide treatment down the road. But I just like this section. And we've covered frozen shoulder in previous weeks, and yep, that's pretty much all I had. So I guess, okay, if we're looking at this thing, I thought that I thought it was interesting because there's like the glenohumeral instability, which I'd probably put more in the category of like secondary impingement. But I don't know. It's like I'm just trying to. Oh, great. Thanks, Chris. It's it's just like from every different like classification system, I'm like trying to match them up to like where they would fit in with this system. Does anyone else find this interesting? I'm gonna stop talking.
Derek, you go ahead. I was gonna say something.
So I do think it's important because, like, one of the things that, you know, I know in class they always talk about pathway anatomic, and if you see this, then it has to be that. But I mean, I do think, you know, listening to what the patient has to say and taking into account their history, social class, like who they are as a person, I mean, is really going to kind of help drive a lot of what we want to do. I know we talked earlier about there's a lot of people who just feel like they have to go, and I got to get shit done, and they never give themselves a chance to really like take a step back. And then we need to try and implement like a break. But then there's those other people who are extremely fear avoidant, catastrophize everything, who aren't doing any sort of movement, who you kind of have to give a kick in the ass and say, you know, we have to get this thing moving, and, you know, put you in those positions that you may not like. Now, I know that there's a better way to do that than, you know, tell them to just suck it up. But, you know, I do think, you know, looking at the person in front of us and what they're telling us is going to be an important aspect as well. I mean, if we have an athlete who had, you know, an acute dislocation, who wants to continue playing that sport, you know, our approach is going to be different than, you know, an older individual who may have had a fall, and we know that surgery may be an option, but more of a passive approach would be more appropriate for that person. And again, that may not be always the case, but I do think that like the history is going to be a huge driver, at least in helping us decide who this person is and how I'm going to start to navigate this. And then we can use, you know, some of our testing and movement screens, however people utilize those things to try and dictate, okay, you know, where does this person lack movement? Are they sensitive here? You know, are they avoidant of this? You know, are they overeager and they just put themselves in that position because fuck it, you know, I got to do it anyway, you know? So again, I think there's a ton of different aspects that we have to look at. And I thought that, you know, they perpetuated that pretty well, at least with the stage of irritability, and trying to understand, you know, where is this person at from an irritability standpoint, and what can they handle and what can't they handle.
What exposure do you students get to like the symptom behavior model? And none of, Chris is shaking his head, none.
I could spell it. That's about it.
Okay. I mean, it's basically what this is, right? Which is basically lumping people into, are they really, really irritable? Are they high pain? And what do I need to do with those individuals different than somebody who's in the middle ground, than somebody that, because our speaking points are going to be different, our education is going to be slightly different, and how we're going to invest in this person as far as within movements is going to be different, right? Low irritability, low pain, I can go after things, right? Which is what this is doing. This is really just a restatement of the symptom behavior model that's been propagated for, I don't know, 30, 40 years. I've been practicing for 25 and I knew about it, right? And so I'm just not sure what you're exposed to within the school system, because they're so didactic as far as what they're trying to get you to do to pass a test, that they may not be giving you all the information that's going to be clinically relevant when you get out. But symptom behavior model in and of itself is just basically identifying the ags and eases, right? And what things and how irritable they are, how long those symptoms are going on, and then driving your treatment based off of those things, right? And so a lot of the testing is there to kind of self-confirm based off of the history that you took. Really, you're ruling out the bad things, and then after that, it's going to be based off of their symptoms and how their symptoms are behaving, and then that's how you're going to load them and how you're going to, you know, put your strategy to get them where they need to go together with them, right? Derek's point is it's a patient-centered model, right? So what are their needs? What are their things? All that other kind of stuff. And the symptom behavior fits within that, because all you do is bring the patient into choosing where their path is and what they're willing to do and what things can't they do type stuff, and helping them through the hurdles of life that they're going to have when they try to do their exercises, and then working with them down that path. It shouldn't be overly complicated. I would say, Kevin, that the reason that you're getting so many systems is it's going to be on the test, and everybody wants you to have a system so that you have a working framework to work from, right? And so choose one that works for you, because right now we don't have a whole lot of evidence that any one of those systems is any better or worse than another per se. Maybe in some of the nocibic language that may be coming out, but the reality is you've got to treat the human in front of you. And so as long as you kind of are patient-centered, the rest of it will kind of take care of itself. It really, really will.
Sam, what are your thoughts on, like, with the low back pain literature, a lot of it's talked about, it kind of chunks it into like non-specific low back pain, and that's really like the common terminology a lot of times now. Why do you think shoulder pain is never kind of classified into that broader bucket, and it's so like there's so many different kind of classifications they have?
There's probably a couple of reasons. Number one would be that it seems like we can create better buckets than just like, when it comes to low back pain, we don't necessarily see like distinct presentations like frozen shoulder versus like this random shoulder subacromial pain, whatever we want to call it. Like we do see more distinct separations than we do with the back, at least from a non-red flag or non-really scary category. Because like with the back, it seems to be like once you rule out anything that could be distinctly concerning, then it leaves you just with this general randomness of a lot of very significant overlap and not necessarily distinct subcategories. Whereas with the shoulder, if you see someone that has low back pain, they all look within reason relatively similar for a lot of things across the amount of time that they've been experiencing it. And exactly, that is definitely different, Logan. But otherwise, like with the shoulder, if you see someone that has a frozen shoulder, it does not look anything remotely close to this sort of presentation, or like an instability presentation, like a multi-directional instability. Like those things look distinctly different, and the way that we'd also provide care for them would be distinctly different. Like I'm not going to treat someone that has multi-directional instability the same as I would treat someone that has, like the later stage frozen shoulder, because like they're going to respond differently to different styles of care. So I think that's probably at least what I would give you as a reason. I haven't necessarily thought about it. That's just off the cuff, but it might be worth just calling everything non-specific pain. You're a human, welcome to life. I don't know.
Well, it seems like SAPS is like the closest version of that, because I guess subacromial pain syndrome, like underneath that, it could be like 1,000 diagnoses that probably don't matter.
Yeah, I like shits.
Yeah, that one's the best for sure. Should I say that on my practical on Tuesday to my professor? You have the shits.
Yeah, that'd be great. I would have been the student that would have said that, so I probably wouldn't have recommended that. That got me in a lot of trouble. But nice, do it up. You get some money for it. So, like in the case of the shoulder, if in the case of like most things, I don't really give like people like a actual legitimate diagnosis. It's really interesting because like I tell people you have these things kind of like generally showing blah 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 blah. Like yeah, you have maybe some reduced range of motion, maybe you have some reduced strength, maybe you have blah blah blah. Like things are pretty obvious when we go through the testing procedure. We sit down at the end of the chat, but I don't really have maybe like 1 in 20 people legitimately ask me for a more distinct like diagnosis. And usually those people have something that's like more distinct. Like when someone has legitimately multi-directional instability and the shoulder's popping out all the time, they're like, what the fuck is going on? Because you can't just tell me that I have shoulder weakness. Like I need to know more of what's going on, because every time I pick up my arm, my shoulder's popping out. And it's like, yeah, we can have a discussion. Like, I don't think that I'm going to give you some CBIC information that's going to like mess you up for the rest of your life. Like you should probably watch what you're doing, because every time you pick up your arm, your shoulder is popping out. Like I just had a patient like that yesterday, and he was having 2 or 3 dislocations per week just doing basic level things like putting his shirt on. He had to pop out earlier that week. And so in his case, like he probably needs to like be quite aware of what's going on, because as he continues to have it pop out and not be cognizant of it, it's going to have more further issues. Whereas like, yeah, if someone has SAPs or whatever we're going to call it, they don't really benefit from me saying, yeah, you have whatever structure's pissed off and that, whatever. It can be much more generalized with them.
That patient example, is that a pretty high candidate for surgery, or what's your,
Yeah, so I'm in Canada, obviously. So our like system to have surgery is a lot different in here than in the US. And people are a lot more within reason, a lot more comfortable with the whole idea of like doing rehab before going to have surgery. And so like in this person's case, like he is a surgical candidate, and if rehab doesn't go appropriately, then he'll have surgery. And I know his surgeon, and we've had the discussion about what that's going to look like. And he has a surgery like tentatively scheduled, just because like that is how they often do it, where they sign someone up for rehab, because his surgery is like, I think like 9 months away, like it's not soon. And so he's basically going to do rehab to a reasonable amount. Whenever we don't see continued progress, then he'll just wait his time out to surgery. He could continue doing rehab if he wants, but it'll be up to his discretion. Whereas like right now he has like a government sponsorship for doing it. So he has
what's
like
the
some of
surgery?
it covered.
What's the surgery that he's going to get?
So they'll like tighten his labrum essentially. Yeah.
I mean, anecdotally, like I had that same procedure. So, I mean, everything he said, I had to go through as well. It was, they wanted rehab before the surgery. Even though I was completely committed to doing the surgery, they wanted as much range of motion, quote unquote, stability as I could get, even though I literally like had none, I felt like. So right up to before my surgery, I was doing as much, more of my own, because I tried rehab and they weren't really getting anywhere. So they just gave me generalized like home exercise to just stay active, keep doing stuff. And then I had my surgery where they essentially like took my labrum and almost like folded it, and then they pin it down with anchors. In some cases, they will do like a tenodesis, depending on the association with like the transverse humeral ligament or anything like that. I had a couple OR rotations during athletic training, so I actually got to see it. So it was pretty gnarly. But again, it is very patient specific.
Yeah, and a lot of times with the tenodesis, they like won't officially decide if they're going to do it until they actually get like in the operating room. And so then they'll just have it like tentatively that we're going to tighten up the labrum. And then if it looks like the tenodesis is necessary upon opening everything up, then they'll decide, assuming the person like clears off that they're okay with that. So that's really common.
Sam, with those, the swimmers that you say you see a good amount of, and then the throwers or any like overhead athlete, is your initial thought with them who are coming in with shoulder pain, like, do you have kind of initial like bucket of like, is it just too much volume that they're handling in their sport? And is that like the first recommendation, or is it really like dependent on the sport and that individual of like, this is my primary thought of what they're coming in with. This may be like the biggest change that I can start with. Or does it like, sometimes it's like, oh, they just need more loading, or they need to pull back a ton. What are your thoughts there?
So at least in my experience, if we're talking about swimmers, without a doubt, no question asked, it's going to be a volume aspect, because like the one that I mentioned yesterday, she is 15 and she swims, let's do the math here, about 16 hours a week. And that's like not uncommon in swimming. So it's absurd the amount of volume that they do, and they like do it year round. And it's very notorious that, especially in the first period when they haven't at least somewhat either survived or adjusted to it, they do end up having some sort of like pain presentation. So again, like this isn't the first, like just with COVID, this is like their first 3 weeks doing the block. And I'm not like the official physical therapist for the team, but I see a lot of them just because the performance gym that they go to is the one that I'm like the on-staff PT for. So then I see a ton of them and I hear from them while they're also training. And right now, a bunch of them are feeling banged up. A lot of them are feeling hurt. And then it'll be that they either survive, take a break, or have some sort of injury across the next while. And then the vast majority of them will adjust and accommodate to it, but it'll be rough for them while they do that because they don't really do a progressive loading. Like it's like, okay, you did nothing for the last like 3 or 4 months. Now we're going to hit you with 16 hours of swimming this week. They don't do like usually a ramp up. They do like a bit of ramp up in intensity, but the volume is pretty much just boom instant. And in baseball, it's probably not quite as bad, but it's definitely at least like where I am, like here in Kelowna, they have a couple of teams that are like higher level for Canada, so it's super desired. Than the guys that are either not on the team or like not legitimate like starting players on the team. They like throw the shit out of their arms all the time. There's a bunch of different places where they can go to get extra practice. And so it's notorious for these guys to go and do like tons of extra stuff. And so then the easiest thing is like, I just know that there's like this place that they can go to called On the Pitch. And I'll just ask them if they go there. And if they say yes, and I just say like, that's one of the first things that we're just going to cut off because I'm not going to tell them to stop doing that. Their legitimate training, like their practice, because they obviously need to do that for their to be participating in their team to the best degree. They don't need to go to their extra practice that they're choosing to do. So I usually will try to make volume reductions where possible, and then look to see where we can fit in some additional training. Like with that swimmer, I see her specifically on Fridays because she swims every single day except for Saturdays. And so she has double sessions every single day. She comes and sees me after her second session on Fridays. And then we do our rehab session because it's the end of her week. I'm going to push her and then she has a day off to recover. So I try to do like something like that with a lot of baseball players where if I know that they're going to be, it depends like if they're in season, which they're not really this year, but other years they might have like 3 or 4 games a week. And then they also have 3 or 4 practices a week. And so then they basically play every single day, which makes it really tricky. But usually they'll end up having like 1 day off. And just for like my schedule and their schedule, it's usually not after their last practice or game, because a lot of times these guys will have like a game that starts at 7 p.m. and I'm not going to go and treat them at midnight. So I usually see them like first thing the next morning. We do our rehab sessions and they have as much time as they can before their next day. So I'm fortunate in the way that I can like schedule around my schedule with them a lot. But a lot of the times like they'll have stuff that they do themselves because I don't see people super frequently. And so then I give them like routines for them to try to implement where it makes sense. We have this really deep discussion about scheduling and trying to make it work. And even if that means that they play a game, they're fucking tired, they got to go home and do some stuff at home, I like really sell and commit them on it so that they make it a priority to then have like some time off before having to do the next bout of challenging activity. And also for them to have some time where they just like don't think about anything. So I want like as much time mentally off of it as well, just because baseball and swimming are both 2 sports where they really like smash the shit out of themselves at a relatively high volume. So
yeah, I will say in the States, guys, you're going to see a lot of people that are like, I've got one right now that plays for his high school team and plays on 2 select teams, because the select teams are the teams that oftentimes are the ones that they're actually being looked at, because we've got a group of high-level athletes all playing together on one field. So if I'm a scout, where do I want to go? Watch one kid that I want to see on a high school team play against kids that don't have the same skill level, or go to games where all these kids are selected out, right? So he's got 2 select teams and his high school team. He's a pitcher on his high school team and plays catcher on his other things. So he is throwing all the fucking time, right? So trying to control those volumes is a big point, right? And all that kind of stuff. So be ready. You're going to see those kind of people where it's year round and it's multiple teams and they have that same kind of a schedule. This guy plays sometimes all weekend. He's got a Thursday and a Friday game. He's got this, and then he's practicing all these other practices. And we'll still go seek out pitching coach or this other stuff, right? So you're talking about mad volume, and it's almost impossible to control that level of volume. But we bring it back and do things with it. But it's sometimes it's crazy.
And so I guess this is for the clinicians, and Sam, it kind of brought the question to my mind, like what exactly, if it's more just like a volume kind of thing that we're looking at with these swimmers who are swimming 16 hours a week, or these baseball players who are playing an absurd amount, like what exactly are you doing during a rehab session? Like after she swam for, let's say she just finished her 16th hour that week on that Friday, and then you come and do an hour session with her, like, are we not just adding more volume? So what exactly are you doing?
Nice, Kevin. Absolutely, you are correct. Sorry, I got distracted there. Yeah, so at least in my choosing to practice, I'm looking at how can I develop the person in ways that they're not fully getting in the sporting activity that they utilize. So for instance, like this person is a breaststroker. So she's doing a motion, or sorry, she's a butterfly stroke. So she's coming up and over like this, having a mad amount of internal rotation challenge. Like she very minimally gets any external rotation strengthening. She's also doing it at, like, while she is putting an effort, the relative intensity of that effort is not like super high resistance effort. So then I'm doing higher level of resistance effort, particularly on like rowing and pull-up type motions with an external rotation emphasis, doing some additional external rotation strengthening. Mostly that kind of work with her. And then we're also looking at, so for instance, this individual specifically, she has tons of range of motion in her shoulder, but her actual range of motion in her thoracic spine is limited, particularly in rotations. Now, not super relevant for when she does butterfly, but she does also do freestyle swimming. It's not her like main event. It's like she does like 3 or 4 different butterflies, because if anyone's involved in swimming, they will often compete in like the 100, the 200, the 400, the fucking mile. Like, it's insane. And then they also will do like some other swimming styles. So she does like all the sprint ones. So I think it's like the 50, 100, 200. And then she also does the freestyle, but for then distance. So then we're working on some thoracic rotation, because you can see that I'm fortunate that I get a lot of footage from the coach as well. He'll just like take stuff on coach design and he sends it to me for the athletes that he knows I'm working with. And so when you watch her swim, you can see that she actually almost exclusively yanks the shit out of her arm. She doesn't actually rotate much of her thoracic spine. And that if you watch how swimming should be done, that's actually the way that you want them to do it, is like to rotate their upper back, because then it can allow them to get a little bit more arcing motion and actually drive in instead of like swinging their arm really high and over. And so like her style of freestyle is inefficient compared to her butterfly. And so like, because when you watch someone do butterfly, they come up and they extend, they come up and over. I've had to learn a lot about swimming. And before I moved here, I like knew little to nothing other than what Bob Comfort taught me. Yeah, so that's like some of the major things we're working on in her specific case, because she has thoracic range of motion deficits. So then we're doing some things that are like light and easy from that standpoint, just because I'm not going to smash her with too much. We're doing some additional strength things, trying to add like one arm rows, for instance, where I let her rotate into the motion to try to encourage it. Then we're also doing some higher rows, some pull down actions where I'm emphasizing her to rotate back as she does the motion, and then some isolated external rotation strengthening. The volume is not super high. Like, I will often have her do, like yesterday, I had her do the arm supported external rotation as an actual exercise, and she would do about 6 to 10 reps, because I was just giving her a heavier dumbbell. However many you get, till you get to about an RIR of 1 to 2, stop, and then she's resting like 3 minutes. Like, she does both sides, so the amount of time to rest here is about 3 minutes. So she'll do this one, rest for about a minute, do the other arm, rest about a minute, back to that side. And so then I actually saw her for like 45 minutes, but in the whole time there, she probably did a collective of like 10 to 12 sets of movements. So she's resting a significant amount of time, really working on having like a high effort and also a high relative resistance. Because when she goes back to her activity, she's going to be doing the complete opposite actions and needing to have that motion more to support her shoulder, at least based off the literature that's there for swimming, because they have very similar stuff from handball.
Awesome.
But it does, sorry to cut you off, Chris, but it does change again in swimming. If you start to look at backstroke, for instance, like, I know I'm not presenting on swimming, but there's a lot of different styles of swimming, and there's a lot of different ways that the swimmers move, and the small details about that. So like, for instance, I just mentioned all that stuff, but the way that I train her for butterfly and freestyle, but if she was a backstroker, which her brother is, and he's also an Olympic candidate, he gets very different things when he sees me, because backstroke is the complete opposite action.
Sam, this is more of like a big picture question, but knowing that you got your education in the States and you've lived here and practiced, I believe, in the States and now back in Canada, is there like a different kind of view on physiotherapy in Canada, and just like patients coming in to see you? Do they have a different interpretation of like what they're expected to treatment to look like, or kind of motivation?
Yes and no. Yeah, so the first thing is that the system for paying is like relatively drastically different. So the first thing is that a lot of people hear that we have like universal healthcare, and they think that means that, like, for instance, physical therapy or physiotherapy is covered, which is actually not. It's not a part of universal healthcare in Canada. Generally, there's a if you are a approved provider under the certain provincial system, so like the state system, you would be eligible to charge a certain number of sessions per month based upon need of that individual. So if they are a lower income status or whatever, there's all this different criteria for it. And so then you can submit for that person to, or that person can submit themselves, and then you can also submit them both situations to have their session covered by universal healthcare. But in the vast majority of cases, that is not what's going on. And it's either private pay or covered by insurance, but insurance is way less common here because we have universal healthcare. Most people don't have third-party insurance. So a lot of times people are paying out of pocket, and they really don't like bat as much of an eye at it. Like when I was in the States, it was way less common to see, like, had people that were called cash-based PTs and stuff like that. Whereas the vast majority of people here are like kind of like practicing as cash-based PTs in a way, like even the bigger clinics where people are just paying cash out of pocket or whatever way. And then they're sending it to their insurance company to get covered most of the time. There is some direct billing that happens, but it's way less common. So people are more comfortable with doing that style of system. And then because of that, I would say that people are a lot more, it's more common to see people coming less frequently. So you don't see as many practicing clinicians doing the mill style. Like there is definitely mills here, but they're not usually doing like 3 times per week for 4 weeks, 12 weeks, whatever it is. It's usually more in the range of like 1 to 2 visits per week for that extended duration of time, just because, yeah, people aren't usually paying out of pocket. It does change when we get into like workers' comp. I'm not a workers' comp PT, but I do hear stories here locally that are like essentially the same issues as in the States. So that part is definitely different. And then it seems to be that a lot of people are, I'd say that where I live is a little bit biased because I like live in the equivalent of Napa Valley here, where it's like a lot more outdoors, a lot more relatively healthy individuals, like more active lifestyle. For the vast majority of people, like cycling is a huge commuter activity here. Like the streets are, it's not a big city, but the street is littered with cyclists from April till November. Like they basically just stopped because we started getting snow, and there's still people cycling right now, even with snow on the road. So people are way more comfortable with like taking a much more active approach in general. But you do see also, in contrast to that, a lot of like guru medicine practitioners here because the community is relatively wealthier as well. So there are a lot of people that are chiropractic, PRP specialists, that kind of stuff, that are providing like outrageous kinds of care for outrageous amount of pricing. Like it's, I have lots of people that come and see me that have just had PRP, and it's like very common where they just like drop $500, get a PRP injection. They'll go a couple of times here and there, and it's I like when I worked in the States, I basically never had someone that just like had PRP done, like no big deal. Whereas here there's a lot more disposable income. I think that like the average income in Cologne is like $98,000 per year. So it's a different population.
Sam, what do you think the general expectation is of like a patient coming in for you? And I know it's somewhat self-selected for you because you think about like all of your patients, for example, like with the swimmers, like they know like, okay, from their other teammates, like, hey, you're going to go in, you're going to be working pretty hard. It's going to be whatever. But I feel like here in the States, at least, like a vast majority of people have like a mindset that like, okay, they go see a physical therapist, and what that therapist is going to do is probably massage them for a little bit, and they're going to hand them a home exercise program sheet, and that's about it. So I think we're in that stage like battling that. So what do you think for you, and then for other physios in Canada, like what is a general expectation? I know it's a giant question.
I'm going to extend this to back when I was in the States. So I can't wait for Paul to jump in a second, but because I'm intrigued, like he's currently practicing very different environment than I was in, being in Texas when I was in California. But nonetheless, I had a lot of patients that would come in with that expectation, but but I still have patients coming with that expectation. Regardless, I think that the way that I choose to sell, the way that I'm going to do things, the way that I choose to present myself. You know, like a lot of times we've looked at the way that manual therapy and all these modalities have been examined, and we like write off a lot of the contextual effects. And you know, personally, I don't provide any of those treatments. Like I've literally never built a single unit of manual therapy as a practicing clinician or any modality. And in contrast, though, I contextualize the shit out of everything I do. I try to make the best atmosphere possible for when my patient comes in. I build the best rapport I possibly can. I'm like going to become their best friend, and I want them to think like the kindest things of me every single time that we talk. And I try to bring tons of energy, bring the heat every time that they go to do stuff. And more often than not, like I literally just had this old lady that came and saw me. She was like 85 years old, knee osteoarthritis. We had like the whole discussion about things, started doing everything. And I was getting her to smash sit to stands. I was like jazzing her up. She thought it was hilarious how excited I was. But then she was like ready to come back and do it again the next week. So, and I practiced a lot like that. Like I worked half-time in a SNF, half-time in an outpatient, and then additionally extra hours in a hospital when I was in the States. And I was the same way the whole time. And like I would go into the hospital, people are in bed, not wanting to do stuff. Nurses would warn me about these patients, and then I'd be getting these homeless people that are drug addicts fucking crushing tug scores with me, doing tons of stuff, getting as jazzed up as I can. And I don't know, like I hear about all these horrible stories about how patients are not wanting to do stuff and all this kind of stuff. And I've had a lot of students come and join me, especially when I was in the States. I would have probably, there's a school that was close by, so I have like 1 or 2 visitors a week for a day. And it was really common where they would just be like blown that I could just have my patients so involved and so excited to do stuff. It was really common for patients to come in and just instantly you could see that they were in a way better mood as soon as they saw me. And I know that's like a personality thing, but I think that an aspect is like, I don't expect that my patients love to exercise, but I expect of myself to make it the best situation I can so that they hopefully think it's less shitty. And like they're in a shitty place, like who wants to come to rehab? I know that I don't want to be injured. I don't want to go to rehab. So I try to make it the best way possible. And yeah, Paul, you were grabbing your cup of Joe when I said, I'd love to hear your stance on this. Yeah.
My stance on what are we exactly getting into?
Oh yeah, I guess you weren't here for the question either. That's a good point. So Nick asked about like, yeah, you go for it, Nick.
Well, I just first off, thank you, Sam. That was like a really cool answer. I think it's great, just like the idea of like really bringing that to patients and meeting them there and providing like some pretty awesome contextual factors. Just because so many places really do have it set up. You walk in, it's like carpet floors, it's these like nice, pretty like spotless plinth. So I think it's cool. But Paul, what I asked Sam is I said, like, what does he normally see? And obviously, I understand that he's relatively self-selected because of the environment he's placed himself in with like some pretty high level athletes in very competitive environments. But like what was his expectations or what did he normally see expectation wise for patients coming in or like as in comparison to like the United States for physios? So a lot of times I feel like in the US, people come in, or from what I've personally seen is they come in expecting maybe they're going to get a massage, then you give them 4 exercises to go do at home. And then you just see them, 3 times a week. So I asked him, and then now kind of what you feel like you normally see with patient expectations.
Well, I mean, you'll get the patient that, if you're asking, have you been to therapy before? So, if they've had prior experiences and stuff, right? And then why are you coming? What are your expectations? You should be asking that question, whether it be goals derived or just what their general expectations are. And more often than not, you'll get either the doctor sent me here, or they're coming basically for the spa because I want to feel better, right? But that goes to Sam's point. If you bring energy, you recognize that context is king, and the context around that relationship is going to be what drives really a lot of their outcome. You focus on that, right? So you're getting in with that individual, whatever means that is. If it's a golfer, you bring everything back to what they really care about. If it's a grandma that wants to play on the floor with the kids, you're bringing it back to that shit. You're always giving them context for why you're giving them exercises. Right? Because if I'm giving them something and they don't see the relevance, even if I know what the relevance is, if I haven't explained it in a context that means something to them, they're not going to be able to do that, right? And then if I'm not bringing them in and going, okay, so do you feel that you can do this? right? If I'm not asking what are the barriers and finding out what those barriers are to exercise, well, I work 2 jobs, I got this. Okay, so we need to fit this into your day because you're not going to set aside 30 minutes to be able to do something, right? So how do I work this into their day? You have to understand the context of their life. Context is king to me, both in the relationship, but also just in how they're going to be able to do anything that they're going to do. And again, one of the things that leads to burnout in healthcare isn't just whether or not we care about the individuals, but it's oftentimes we bring a lot of energy, right? And you're giving a lot of your energy away, right? And that's why like meals get tiring for people, because if you're really trying to do your job and bring it to 20 some odd people every day, you don't have that much energy to give when you get home, when you do anything else. And so you don't have that extra life, right? If you're trying to keep balance, you've given away so much energy. So it is one of those things. And that's why people fall into that rut. And that's why people get into, but then they're no longer inspired by their work, right? They're no longer inspired by the people because they can't give that amount of energy anymore, right? So it really is helpful. Like Sam's able to self-select. I self-select somewhat, right, in my current practice, right? And so I'm able to do that. I don't have to see 20 people to pay all the bills, to pay the middleman, to pay all that other kind of stuff, right? So that's a different world. And that's why it's enticing for a lot of people. But I will also say that if you're only seeing 4 to 6 people as a new grad, sometimes you're not getting the reps required to really build a strong basis of what you're going to be doing, right? Sometimes reps are required for anything, right? And so getting those reps is valuable as well. So don't just because that job offer, oh, I think they're going to burn me out. Use that as getting the reps. Get that in. Figure out your spiel. Figure out what you're going to be doing with these individuals, how you're going to be handling them, and then go do your thing, right? So there's a learning curve to everything. And so it's not a bad thing to be there. You just don't want to, that's not your career path, right? That's where you're going to hone some skills and then you get the fuck out.
Killed it, Paul. Sam, I have a question about, say, like that swimmer example. You have them kind of specifically doing the motions or the positions that they're not used to, or that they're not training as much in their position. Where's the point where like you train other qualities for them of like they're a swimmer, but you're going to train like lower extremity, even though they're coming in for shoulder pain? Like, how do you differentiate between like training a client and like, oh, we're just rehabbing that part?
I guess like the biggest thing is like, why are they saying me? So I work with a lot of swimmers. So right now, yesterday, I don't, kind of like to Paul's point, I don't see patients. I don't see 20 patients a day. I don't actually see patients every single day, unfortunately. I used to do that. Don't get it wrong. When I was a new grad, exactly. When I was a new grad, I had 4 jobs my first year in practice because I wanted to get the reps. I thought that was a really big deal. I wanted to feel comfortable in any and every setting. So I worked in acute care. I worked in the ER there. I got to work in a SNF. I got to work at an outpatient. I got to work in a neuro rehab. So I was very fortunate. I just worked the shit out of my life. But now I only saw, this week I only saw patients 3 days, which is wonderful for me. But yesterday I saw a lot of swimmers, and 2 of them actually drove in from Vancouver. So for anyone that doesn't know, it's like they drove roughly 4 hours to come see me. They come to see me once a month. They're, again, 2 more swimmers. They're Olympic trial competitive athletes. They came in, we did testing for their entire body because I'm going to be their performance coach. They're coming to see me specifically for that. So I'm not billing insurance. Like that's not an option, nothing like that. Like they're coming to see me as a strength and conditioning coach, whatever you want to call it. And so now they get some like rehab stuff, like they have a history of injuries, they have whatever. I'm going to take that into the context of how I choose to program, but I'm treating their entire whole body. In contrast, when I saw the female that I mentioned yesterday, she goes to a performance gym and has performance coaches, and they do all that kind of stuff. I'm friends with those people, and so that I know what they're doing as well. And but she's coming to me specifically for shoulder pain, and so then I'm going to be treating her shoulder and upper body as a general. I'll just say because it's in the context of what I need to work with for that. Because I don't see on my part, maybe in a different case, in a different activity, I might argue that you could train legs to benefit the shoulder. But at least in her case, I don't see how that's going to benefit the shoulder, so then I'm not doing that. So I'm going to be treating her upper body. I'm also speaking with her strength and conditioning coaches that she goes to She used to go to them twice a week, but now because she comes and sees me, she only goes there once a week. And I speak to them about what I'm doing and what are some things that they could do with her safely. So in those situations where I'm legitimately doing rehab, I don't usually treat the rest of the body unless it would be appropriate.
I have a quick question. When you're doing the coaching, if they develop a small injury, not anything too crazy, how do you transition? How do you decide whether to transition them over to PT or like change their loading as a coach? Like, where does that change? Because I'm sure that monetarily you have to make that decision at some point, whether to be a PT or a coach. And I know you can still manage their injuries through changing load and stuff. So where do you make that decision?
Do you mean like if I have a performance athlete and they have an injury, how do I differentiate that?
Yeah.
That one is tricky. So I'll say that I'm at least like relatively fortunate. And also, not that my athletes don't ever get injured. They do get injured more often than not. It's what you could call a minor injury, whatever that would mean, but doesn't normally cause a significant disturbance in their training. So for instance, I have a soccer player that I coach, like a pro soccer player, and he just recently started to experience like some lateral knee pain when he was doing agility movements. So he's and so the pain was causing some issues, but I didn't see how I necessarily needed to treat it. I just made some changes in his programming to see if it would accommodate reduction in his pain. So we did that. We had the first week where I just like modified what he was going to be doing. I still saw him once a week for our coaching session. We went about everything else. I gave him like a quick little spiel about not worrying about his knee too much. The rest of the time we just like stuck to his performance stuff. And then he did the same thing the following week, same week the following week. Then when it was his fourth week, he went back to totally everything because his knee pain was gone. So if I don't think that I have to like disrupt our standard training to continue or because of the injury, I don't normally shift them into a rehab situation, because if they can continue to train and not be like, yeah, they're limited, but they're not like drastically limited. Like if this person like fucked up their knee and now that they can't train lower body, and now we need to specifically like figure out some solutions how to train their lower body, that's a situation where I would probably put them into the context of becoming a like a rehab patient. But that doesn't, at least for me, happen too often. A part of it is that I don't have a ton of performance people that I see probably. So if I had like a way higher volume, I might have that more of an issue. But right now I have in-person swimmer, soccer, basketball, MMA. So I have 5 people that I see in person on a for a performance standpoint, and then I also have 2 people that I see for just like fat loss or whatever. So I guess like 7 people, and I've only had to shift one of them ever into a rehab situation. The rest have all been like things that we can manage very easily without needing to do additional sessions or anything like that, or like distinct training efforts, and it's just like very manageable. I'm also like a pretty big like generally train, generally be active, generally be healthy, all those kinds of things. And natural history will do a great job usually. So a lot of my patients like know who I am, and or my clients, I should say, know who I am. And they know my general philosophy. And so more often than not, they buy into the process and they trust what I say. And if one of them had pain that lasted like weeks on end, then I'd probably make a bigger shift. But more often than not, I don't think I've had too many people where whatever like nagging little thing that they've had has distinctly interrupted training for very long. That same soccer player actually had like a Achilles tendinopathy pop up when he got back onto the field in June when everything opened up initially. And so like he went on the pitch and he just started like smashing sprints because he was excited to be back out with his team. And he had like some pretty significant like pain from Achilles tendon. And so in that case, like we modified his training fairly significantly, but I didn't feel like I needed to do like a whole session devoted to it. And so then like we basically just continued to train, and I reduced some of his stuff from a standpoint of his lower body movements that he was doing, and I shifted more towards like an Achilles tendinopathy management. And we basically just like continued to train, because in those situations, like I'm still being paid. So like I don't really mind. The only thing that really would change it would be like who ends up paying. Like, is it the person paying me for performance because they can't bill that? or do they need to for some reason now start to have insurance cover it? And so more often than not, these people that are paying me aren't needing insurance to cover it because they're paying me either way, and they don't necessarily need insurance to cover the bill. So if they were lower income status, and it might be a different situation, but I personally don't have that, so I can't really speak to it.
Dope.
Yeah, that was helpful. Thanks.
All right. Does anyone have any last questions? And then we'll wrap it up.
Awesome. Nice hanging out with you guys.
This was great. Thank you so much, man. What time is it in Canada right now?
On the west coast of North America, it is 9:41 a.m. Same time as California.
Oh, okay. Not
Yeah.
too bad. Well, thanks for doing this, man. I appreciate it. I know I got like derailed from the shoulder in the end, but I think it's fascinating, like your setup and being in Canada. So I think a lot of people were curious about that as well. Shvi, all right, man. Enjoy the rest of your weekend. I appreciate it. And everyone else, thanks for joining the party.
See you guys.
All right, bye.